So what can we do better? Actually, a lot. If we look at the ACL medicine, so to speak, one important thing is to increase the evidence base, but it's pretty difficult, and I'll show you why in a minute. And actually, so the evidence base is made of the scientific evidence, clinical expertise, and patient expectation. It's not only about scientific evidence. That's really important. So it's a continuum of growth and of knowledge that we gather in these different fields that I've listed on the right side. Actually, if you have to deal, when we had this IOC Research Center meeting, we were in a minority as orthopedic surgeons, and there were a lot of researchers like Marco. And in order to make them understand how actually innovation in orthopedic surgery goes, and if you become an orthopedic surgeon, one of your passions is about technique, about surgical technique, about doing new stuff and so on. So it's a permanent innovation cycle that we are undergoing, and it's of course difficult to bring science into this. The way that real scientific people understand it. And so that's why we have promoted over last years this chart of adoption of innovation in orthopedic surgery, which starts with a good idea, basically. You have an idea, you try to bring that to your patients, and then you need to develop the procedure. It needs, of course, to be validated externally. And then you need to assess it, to consolidate it, to bring more knowledge into it, and then it all ends up in the long term with, I would say, RCTs and then long-term trials. And that's how it goes usually. You have a couple of innovators and early adopters. That's 16%. That's really important. If you bring something new to society or to an environment, you will have 3% of people who believe in you, and to try to help you to bring it forward, and also some 13% of early adopters of your techniques, of your ideas, and so on. And the interesting thing is that from an, I would say, more psychological point of view, this corresponds to a specific character of each individual. At the beginning, you have the visionaries. Then you have the competitors, they push something through. Then you have those who try to get knowledge around it, to get consensus and so on. And then you have those who just believe in science. And if you live in Europe and you work there, you know that there is a gradient from north to south. And I let you think on which character corresponds to which part of Europe. Elizabeth is laughing, so she knows exactly what I mean. So that's a little bit to understand how we work and how we function. And so, of course, and then we bring this science in an environment, and these environments are different. They change from time to time. And in Europe, for instance, we have this societal environment with GDPR, which is data control and so on, and then the new medical device regulations, which kind of turn our markets upside down and so on. And so that's why things are changing. And this is, of course, also something getting into the ACL world, and which is important for the ACL world. So the ACL problem in 2023 is a global one. And you see here a recent publication of more than 12,000 articles showing on the left side from which countries these publications on ACL were coming from. You see a majority coming from the US, but then from all over the globe. So it's really a global problem. And you see here Qatar and Luxembourg, that's where we are from, still small parts, but we're getting bigger, I promise. So on the right side, you see the exponential curve of publications, which you find in many, many fields, because there is a 7% inflation in scientific production every year. So you need to take that into account as well. So this curve is pretty similar to the evolution of ACL injuries in Australia, not only in Australia, but in most part of I would say, the Western world. And this is worrying. Why? Because if you compare these incidences of ACL injuries, we're getting close to the incidence of femoral neck fractures we have in our Western countries. And that's really worrying, because that's a well-recognized public health issue. So we are not far away with our ACL injuries from becoming a real public health issue, and also, especially if you look at the consequences in the long term. And if you compare this with the evolution of traffic injuries or occupational injuries in our societies, then you see that it's just the opposite that happens with ACLs. What about the age distribution? You see here you have basically three categories of ACL injured patients: the under 20, then 20 to 35, and then the leisure sports over 35. And in orange the men, and in blue the female. You see that you have two peaks in females, at least in our country. The left is ball sports and the right is alpine skiing. Now the left category is the one which is the most worrisome. Why? Because it's the one with the highest increase of incidence. These are the patients who have very, very often a positive family history, something which is very frequent here as well. 2 days ago I saw a patient here, and I asked him about this, and he told me, well, we had 15 ACL injuries in our family. So that's really big. That's, in my personal experience, the record, right? 15, that's great. And actually many of those have re-tears. We have a high re-tear rate on the ipsilateral side of around 15% in this under 20, and the secondary rupture rate, so on the contralateral knee, same thing, 15%. That's really a problem. So there's something in we don't get it. Is it genetic? Is it whatever? Is it the evolution from adolescence to, or from childhood through adolescence and to growth? We still don't know. Again, one thing is sure, something we see in our societies very often is that actually, well, you get an ACL injury, well, you get operated, you will end up on the podium anyway. So it has begun, there is a kind of trivialization of these injuries, of these severe knee injuries, which we see in our countries, and which is worrisome because it's not that easy. And it doesn't really correspond to our daily reality. That's more or less the daily reality. Majority of patients we see. Here you see a 36-year-old guy a patient I saw a couple of weeks ago, had an ACL injury and a loss of the lateral meniscus 17 years before, and now he has pain at activities of daily living, and he has a working job, and he has an invalidity. So that's, I would say, our daily business with ACLs. It's not about the gold medals, but it's rather the opposite of the spectrum. And we know that this is the start of the degenerative cascade, and this starts very often with a sports injury. And so this is a chart I've published a couple of times, and we keep on showing that, especially also to orthopedic surgeons, that it's our goal to keep the patients as long as possible in the green zone here, because we see in our department many, well, I would say on a regular basis, patients which are in their 80s, in their late 70s, and which we need to amputate because we can't get hold of a complication of knee arthroplasty, of infections and so on. And so that's something we have to have in mind from the start and work on that. It's really important. Because we are not that good if we do ACL reconstructions, for instance. This is a publication that was just released this week in the ASCA journal, where it's coming from the German ACL registry of German football, and they looked at return to competition after primary ACL reconstruction, 8.2 months in professionals, 12.5 months in average in amateur players. The 3-year dropout rate was 20% in professionals and 37% in semi-professionals, and the return to the same level was only 28% in amateurs and 47% of professionals. So that's really bad, both for professionals and for amateurs. And I think the difference between amateurs and professionals is probably the physios, because they got better rehabilitation. But then there is somewhere there are limits to what our human bodies can do. One thing, if we look at ACL injuries and the presentation of the results, is that very often we have a generalization of results. So all of them are put into one pot, and then we look in big meta-analysis of randomized controlled trials or prospective cohorts. We look at the differences, and we don't find differences. Why? Because in these patients, because everything is put together, and an ACL injury, as I showed you before, in an under 20-year-old has nothing to do with an ACL injury in a patient who is over 35. So, but let's have a look at other new stuff. Surgery versus non-operative approach, still a big question. In Europe, this is very predominant, I would say, more in the northern European parts of the continent. And actually, you can take different variations. And I know that my colleague surgeons, they are struggling with physiotherapists who have a very strong feeling about non-operating the ACLs. And of course, there was strong science showing that some RCTs were pretty similar to whether you operated patients or you didn't. And so as you see here, and that's of course worrisome because we see a negative selection as surgeons, a negative selection of patients. So fortunately, there has been recently very, very good science coming out here from the Lancet, for instance, that ACL reconstructions is superior to a non-operative strategy here at 18 months follow-up by the Oxford group and around David Beard, great scientist. And also from the Scandinavian registries, they come up now with studies showing that there is a superior outcome of early surgical versus initial non-operative management. That's basically good news for the surgeons. And they showed nicely that there is a greater risk to develop intra-articular lesions with initial non-operative treatment. And that if there is a crossover, they had an increase in meniscal tears and chondral damage. So here another study showing a really greater proportion of patients reporting actually better results after surgery than after non-operative treatment. So I think that this seems to be clear. Now we need to get better in fine-tuning our indications, that's for sure, and that's what I will show you now in the next slides. Actually, what happens if you don't operate an ACL, in ACL injury? Very often we have these knees who decompensate, and that's a concept we kind of forgot over the last years. We know the end stage of decompensation. You see it on the right slide. That's then you develop, and the knee develops a chronic anterior tibial translation. And very often you develop what we call a cupula here on the posteromedial tibial plateau. But between the ACL injury and this end stage, we haven't really looked deep into it, into recognizing the early stages of decompensation. That's something with my research and clinical groups we looked into over the last years. And we worked here on this, what we call the PCL angle, which is highly pathologic in this case. You see here, the PCL angle is actually the angle between the tangent line of the PCL and the posterior cortex of the femur. And if this is under 22 degrees, then you have a pathologic PCL angle translating an anterior tibial translation. This can be acute, where it can be reversible, but it can also, in chronics, it's really, really very evident. And in these cases, very often it's not reversible. So that means that in the sagittal plane, which is the plane we have forgotten about over many years, we fix sometimes our ACLs in a bad position. Now, if you lose, for instance, the medial meniscus, the posterior one of the medial meniscus, the higher the probability that you have an anterior tibial translation. So we need to look into that much, much better than we did in the past. And we've known that from another study done by our group, that knee decompensation starts very early. And we found it within the first year after ACL reconstruction, basically, where we found a strong correlation between the anterior tibial translation and the tibial slope, for instance, and we found that in average we had a 0.3 millimeter translation by degree of posterior tibial slope. So there are other morphological factors which play a role into this. It's not only about the injuries, but also about the patient's individual morphology. And that's something you can find also if you do one leg standing x-rays, lateral x-rays, and you compare the healthy side to the injured side. And you see here on the right radiograph, you see that there is an anterior tibial translation that increased with chronicity. So more than 4 years from injury to surgery in non-operative patients, we find this anterior tibial translation, which is a premise of probably later meniscus damage and osteoarthritis. What happens in terms of rotation if we do not operate on ACL injuries? That's from another study we found here, where we did systematic Lachman test and pivot shift in patients under anesthesia before surgery. And here we found very nicely a correlation between basically the amount of meniscus damage and the pivot shift, the degree of pivot shift. So the amount of grade 3 pivot shift phenomena was much higher in patients who had a lot of meniscus damage and where the delay from injury to surgery was high. So that's again, so these knees decompensate not only in the anterior plane, in the sagittal plane, but also in the rotational plane. So that's why we talk about the sagittal decompensation and about the rotational decompensation. These are concepts which need to be more validated, but which are really important for us to look into the future in order to understand our ACL injuries and the outcome much better. Now, what about surgery? How to perform ACL reconstruction in 2023? We still haven't found the right graft type, and many of them are available. You see here on the bottom on the right, there is no difference in terms of cosmetics if you harvest either BTB, hamstrings, or quad tendons. So that's really one point which is okay. If you look at the choice of the graft choice from the ACL study group, which is a group of, I would say, 150 global specialists in ACL surgery. And every 2 years, we make a survey of which are your preferred grafts and so on, your preferred surgical techniques. And you see here, in 1992, there was a vast majority of patellar tendons which were used. And then you had an increase of hamstring tendons. And now you have gradually, there was shortly an allograft, I would say, rise. And now we have quadriceps tendon, which is growing increasingly, I would say, worldwide, and probably more in really high-level athletes. Here again, a difference between primary and revision surgery. On the left side, you see primary in dark. That's a majority of surgeons who chose that. And in revision, then they go for stronger grafts, be it hamstring, be it patellar tendon or quad tendon. This is our own preference. You see here, that's from our in-house ACL registry, where we have in 2011, we looked at 250 cases in 2011 and 2021. On the left, that was 10 years ago, where we had basically two choices, which were patellar tendon or hamstring. And now we have an increase in quad tendon, and that basically reflects my activity. But that's not science. This is eminence-based. And so there again, we need to bring more science into this debate of graft choice. And especially, as I mentioned previously, the youngest patients. We know that in young athletes, especially, we have higher re-tear rates for hamstring tendons than for patellar tendons. This has been nicely shown in the last years. And you are probably aware of the discussion that emerged from Belgium 10 years ago, exactly 10 years ago, where they identified the new anterolateral ligament. And from there was a renewed interest in the peripheral structures of the knee, and also in anterolateral procedures like the modified Lemaire technique or the anterolateral ligament reconstruction, according to depending on your preference. Now, what does this extra-articular reinforcement do? Basically, there's a very old study from Lars Engebretsen from 1990. Actually, he showed very nicely that if you add a lateral extra-articular tenodesis to your ACL, you take basically 40 to 50% of the forces that act on your ACL. You're able to take them away. So that's really interesting. And that's something we have used many times in the past. We're still, I would say, discussing about indications to when adding such a procedure, and actually at high risk of failure. Some of us use it in high-risk patients, whatever, so in the age of under 20. I have more morphological criteria. If I have a patient who has a hyperextension, for instance, or a grade 3 pivot shift, an increased posterior tibial slope of more than 12 degrees, there again, it's a big difference if you are in Asia or in the Middle East, because patients here have by nature a higher tibial slope than they have in Europe. And we also add this if we have an increased anterior tibial translation on the lateral monopodal stance X-rays or in revision cases. And actually, one thing is sure, that you reduce your graft rupture rate heavily if you use it. And this is again from the ACL study group, the utilization of extra-articular augmentation. You see that there is no consensus, so the spectrum is from always to never. And there again, we need more science. But again, science is coming. You see here publications from 2022 showing that there is a growing evidence that LET decreases the re-rupture risk by 2 to 3 times, both in a general population and in highly active and elite level athletes. So far, the ideal graft combination is unknown. Should you add the LET only if you do hamstrings, or should you add the LET with the other grafts as well? That's not clear yet. Actually, one thing where we are very, very, I would say, poor in terms of knowledge and of science is really the graft choice and sport specificity. There is very little science around. And I make a plea to an institution like yours to look into this, because you have all the possibilities to work into that and to look in, depending on the different sports, which grafts are really the best to use. Now, an important chapter where we made a lot of progress over the last years is the ACL-associated new meniscus injuries. And we organized a congress called the Meniscus in Luxembourg, where we got 400 people from 40 countries, where basically we agreed that the future of ACL reconstruction is meniscal repair. That's really important. And why? Because 1/3 of meniscus injuries were missed in the past, either by MRI and or arthroscopy. And these were the ramp lesions, these were the root tears, and so we wondered why this could happen and when these injuries do occur. And here there's this wonderful video coming from our Italian colleagues, from Alberto Grassi, around Stefano Zaffanini, whom you know pretty well, and they showed very nicely that in many, many cases, actually, you have really subluxations of the knee. It's not only about the classic valgus collapse, it's really subluxation of the medial compartment, and then basically they have like a shoulder dislocation. What happens if you have a shoulder dislocation? You have a Bankert lesion, so that's probably the explanation of a ramp lesion. And you see that on the medial side, we have those, and on the lateral side, lateral compartment, you have these root tears and lateral meniscus instabilities. And so let's have a look at the medial meniscus lesions, so the ramp lesions. We find them in 25% of our ACLs. And this is more frequent than the lesions we have in the meniscus body. So those you really need, you see very nicely, because to detect the ramp lesions, you need to go posterior in the knee to the posterior compartment. That's what the ramp is. Basically, it's the attachment between the posterior part of the meniscus and the tibial plateau. And on MRI, sometimes you see them. In most of the cases, it's really not more than a guess. So that's why if you have this bone marrow edema on the posteromedial side, that's an indirect sign that it can be present. We showed that in another study. And should they be repaired? That's a big debate in the surgical field now. There is increasing evidence, both from in vitro and in vivo data, that it makes sense to repair those lesions. And actually, there's also some clinical results going into this direction. I can't tell you today 100% if and when it makes sense, but I think the indications are getting closer, or the evidence is getting closer. That's what you get if you look into the posterior part of the knee. You see this is a posterior view here on the right side. You have the femoral condyle up here, and there is the meniscus behind, and then you have a big hole here in the meniscus, in the meniscotibial, between the meniscus and this ligament and capsule. And that's how we repair them. On the left side, we do two posteromedial portals to repair them, to go in. And you see very often that there is a big hole, and that's something you can't see if you enter with your arthroscope into the knee from the front. So you need to go to the back, and then you repair them basically from the back. That's how we do that. And here we did actually what we call a double row repair. So that was in a pretty acute case where we repaired first the ligament. You see here the meniscotibial ligament. We don't operate with tourniquet, by the way, so that's why it's bleeding. And here the ligament and the posterior part of the meniscus. You have a small hook where you can do this. That's a technique we took from the shoulder surgeon to the knee. Then we bring growth factors into the knee with fat tissue, but that's not done on purpose, I would say, in this case. That was the first row, the ligament, and then we take the capsule and suture the capsule on top. And it's pretty much like what we see in Bankert repairs, right, in shoulders. So if you do shoulder arthroscopy, then it's easy to do that. If you don't have these skills, that's really difficult. So that's why we have these debates. And that's actually the end procedure. I want to see if we see the capsule at the end, because you really can tighten the capsule. So now we bring the knee in extension, I think. So here you see that's nicely stable. Bring the knee into extension. and then very often we see that the capsule is tense again, and so the hammock is really tense again. So that's you see this difference before and after surgery. Hasn't been that much deeply described in the literature. So there are classifications of this type of injuries, but I would say this is still work in progress because it's comparable to shoulder capsulolabral injuries, which are still being investigated. On the lateral side, we have what we call lateral meniscus root tears, also pretty often, as we find them as often as actually other lateral meniscus lesions. And here again, there is biomechanical evidence that we should do that, also in vivo evidence, because you can decrease the pivot shift if you fix the posterolateral root. That's the classification we use. The most frequent we find is actually the type 1 and the type 2 tears, where you really need to bring this, that's like a radial tear of the meniscus. That's one of the reasons why we keep them on crutches for at least 4 weeks after surgery. And we identified also another lesion on the lateral side of the meniscus, which is a kind of lengthening of the attachment. You see, that's what we call the type 4 lesion of the focal classification, and we developed a specific test. It's called the aspiration test. You bring the shaver in the knee, you open suction, and then all of a sudden you see that the posterior part of the meniscus falls into the joint. And then we detach it, we fix it back, and you get a stable posterior horn of the lateral meniscus, which adds a lot to your stabilization. And if you don't treat this type of injuries, you can have patients who can come with persistent pivot shift phenomenon, with pain, with cartilage degradation, with recurrent effusion, and so on. So it's really important to fix them when you do surgery, and there is evidence now that basically 80% of them do heal pretty well. We found also that if you don't see a meniscus lesion of the posterior horn on the lateral meniscus, very often, which is very often the case, and we do this aspiration test, in 1/3 of the patients, of the ACL injured patients, we find that there is positive mobility, so a too high mobility of the posterior horn of the lateral meniscus, which shows indirectly that there is damage to these fibers, to some of the attaching fibers. That's really complex, the anatomy in this part, and that's why we fix them as well in order to get rid of this instability. So now, actually, if we have an ACL, we're talking about ACL injuries, right? So, well, we're talking about multi-ligament injuries or ACL injuries. If you have an ACL injury, we put everything in a pot. And that's what I told you at the beginning. It's not really good. We need to differentiate our indications and our diagnosis. And that's why we wanted to work on what we call the severity profile of ACL injuries. If you bump with your car into a wall, which I hope will not happen to you, the first thing that you do with your car is that an expert from the insurance is coming and looks, well, is the car good, or which is the amount of damage? And that's something we don't do in our ACL injured patients. So we have the ACL indication or the ACL diagnosis, but we don't look at the rest. And we have no tool really to put all the damage into one tool to evaluate the magnitude of damage. And you see this very nicely if you compare actually the meniscus diagnosis in ACL injured patients. That was a study we did where we analyzed more than 100,000 ACL injuries from many countries, and we looked at the associated meniscus injuries, and we found that in the US and in our country actually meniscus diagnosis was very high, whereas in the UK it was very low. That doesn't mean that there are no meniscus injuries in the UK, but that probably the surgeons didn't look at them. And so that's why we wanted to develop a tool to really quantify this associated damage, both to the cartilage, to the meniscus, to the subchondral bone, because we know that they are important predictors for recurrences, for poor functional outcomes, and for the development of knee osteoarthritis. And that's something we published already some years, that isolated ACL injuries cannot be compared to ACL injuries with a large amount of additional tissue damage. We have no tool. So our goal was here to develop a tool to quantify this nicely. And that's what we published last week in the ASCA journal. So we combined the data both from MRI and arthroscopy to develop a score with a total of 12 points, looking at damage to ligament, not ACL, because ACL is the premise. ACL injury is the premise to get into this. but we looked also at the associated medial collateral ligament injuries, which are not major, so we took out the grade 3, but the grade 1 and 2. This is a very important indicator to actually a damage in the medial compartment. We looked at the meniscus injuries, differentiated between stable and unstable, minor versus major, ramp lesions, root tears, and so on. We looked at the bone bruise, fractures like the second fractures, lateral femoral notch fractures, posterolateral tibia plateau fractures, and we looked at cartilage, but high-grade cartilage injuries, which got along with this ACL injury. And then we kind of found that 3 categories. ACLIS, ACL injury severity scale 1, 2, 3. Grade 1 was under 3 points, grade 2, 4 to 7 points, and grade 3, the severe injuries, 8 to 12 points. And we found that actually the more severe the ACL injury was, the higher the probability was that you had an participation of the medial compartment. And if you remember the video we saw previously, that's where we have these subluxations in the medial compartment. These are the worst ACL injuries. And we looked in our population of 100 patients which we selected. We had 35% of minor ACL injuries, so roughly isolated. 18% of grade 3, so the severe, which is ACL plus plus 2 meniscus injuries, major meniscus injuries, and probably cartilage and subchondral bone marrow edema, and then 47% which were in the middle. And I think in the future we will really need to differentiate these types of ACL injuries, because they are probably important predictors of the future. And also this will probably allow us to be more precise in our indication making of ACL surgery and in our clinical recommendations, so to speak. So we still don't know what is the impact of the severity. Of course, our score needs external validation, and it needs a prospective follow-up in order to see what the outcome will be, and if it will depend on the ACLIS grading, so to speak. Of course, it will depend also on the activity of the patient's individual activity, of his or her risk profile, and probably also on his or her morphology. We talked about the tibial slope and other morphological factors. So you see ACL surgery and research in 2023. There are many ongoing innovation cycles. We like to play in orthopedic surgery with our tools in the OR. We like to test new stuff and to bring, it's for the good. It's not only for our own pleasure, so to speak. But it's very difficult to bring science into this. And I hope that you understood how this functions over the years. We also know that evidence always follows innovation. So let us play first and then bring evidence to what we do. And we need to strengthen actually the evidence base towards early surgical reconstruction. That's basically my bottom line. We need to recognize this associated meniscus damage, because you have a couple of weeks or a couple of months where you still can repair. I'm thinking of major lateral meniscus injuries. So if meniscus is getting lost, then it's basically the end of the knee. And that's really something we need to understand and to do better in our professions. And finally, I showed you the creation of new tools to grade injury severity and anticipate basically knee decompensation, the concept I introduced you to at the beginning. Now, vielmals merci, that's how we say shukran in Luxembourgish. And thanks to all my fellows who worked with me over these last years. You may recognize one or the other who passed over here. So thanks for your attention. It's a pleasure to be here.